So for today, what are we going to do? Our day today, after a very successful 3 days, concentrates on innovations for sustainable workforce. Throughout the last 3 days, we've been learning from each of our amazing presenters the importance of collaboration. This is a great example of regional collaboration. Here you have 4 institutions that are totally committed to work together to eliminate isolation, to eliminate and break the bridge between silos, and really around promoting and embracing wellness that is person-driven, culturally valued, and that addresses all intersectionality factors. So today, like the previous days, we're going to be hearing even more about recovery. Today, we're going to be learning a lot about the importance of peer support within the mental health space and behavioral health space. We're going to hear opening remarks for Paolo Del Vecchio, who is the director of the Office of Management, Technology and Operations at the Office of Recovery of Substance Abuse Mental Health Services Administration. It is an honor because it's a very new position, so we are very happy to have Paolo Del Vecchio here. We are going to have a future presentation by Dr. Jonathan Edwards, who is a program consultant and an amazing researcher and publicist. I will tell a little bit more about in a little while. Mindful break. Every week we've been in acknowledging of wellness, and so you all can stay fully attentive throughout the 2 hours here today. We invite you to join Sarah Johnson, one of our partners. She is a training at the Institute of Maine. Then at 12:10, we'll resume with an amazing panel that's going to be talking about innovative and sustainable workforce examples. Dr. Ashley Stewart, who is the Director of Health Equity at C4 Innovations, is going to be lead the panel. And the previous speakers will remain. So everybody, if you have questions, we are hoping that all of them will be addressed. So you will hear from 3 amazing programs: Proceed Inc., University of Texas Rio Grande Valley, and the Mental Health Access Program. Then we will be followed at the end by following remarks from Dr. Janice Tandora. She is the principal investigator or co-director of the New England Mental Health TTC. So now, with any further ado, it is my honor to introduce you to Paolo Del Vecchio, Director of the Office of Management, Director of the Office of Recovery at SAMHSA. Paolo?
Good morning, and thank you, Maria. Very much appreciate the opportunity to be here this morning and to provide some welcoming remarks on behalf of U.S. Department of Health and Human Services and the Substance Abuse and Mental Health Services Administration, or SAMHSA. I want to congratulate the New England MHTTC for putting together today's event and participating in the past 4 days of what is really very much a much needed opportunity for us to focus on honoring the workforce, solutions to support care for communities of color. What's really exciting about this work for SAMHSA is that it targets several of our key priority areas. First of all, workforce, as we know, is a critical need across the nation in the terms of developing and supporting and sustaining a quality workforce that it can help to meet individuals' needs. Second is the issue of equity, and certainly the need to increase our supports, culturally competent, culturally congruent supports to communities of color and other groups across the nation is clearly evident as well. I'll say, just on a personal note, as many of you may know, I'm identify as a person in recovery from mental health addictions and trauma. I'm also a family member and a provider. And I know how difficult it can be to be a behavioral health care provider in today's environments, and the need, as Maria says, to focus on wellness and support for people who provide services is critical. And the need for providers to take care of one another and to practice mutual and peer support among one another is also an important solution for us to look at. Office of Recovery at SAMHSA is very much a new effort, the first time ever, in fact, that a federal organization has designated an office at the level of the highest level within SAMHSA to focus on supporting recovery for people with mental health and addiction issues. As we start out at the office, just want to share very quickly our overall 5 goals. First goal is inclusion, the need to involve people with lived experience in all aspects of behavioral health care, nothing about us without us. It also means inclusion. It means addressing what we've called stigma, the social inclusion, the need to overcome prejudice and discrimination that is such a barrier to us for recovery. Second goal is around equity, in fact, and the need to enhance recovery opportunities to underrepresented and underserved communities, including people of color, LGBTQI plus populations, rural, veterans, and youth as a particular focus. Third goal is around peer services. So excited that Jonathan Edwards is here to follow my remarks to talk about this type of work. And we know peer workforce, incredible growth over the last 10 years. SAMHSA and our work at the Office of Recovery, and Jonathan was actually just involved in a technical expert panel that we had last week, developing a model national peer standard, peer support specialist standard to help guide state efforts across the country. It's exciting work happening there. Our fourth goal is around social determinants, and we know that people need health, home, purpose, and community in order to achieve recovery. And so the importance of things like housing and employment, education supports are critical for our recovery. Final goal, as we've talked about already here, is wellness and the need to not only focus on our behavioral healthcare needs, but our primary healthcare needs as well. The need to better train providers and primary healthcare providers in order to better meet and serve our needs. In addition to these 5 goals at the Office of Recovery, we also see 3 things as critical importance. One is data, need for more data and evidence around recovery and what works. The second is trauma, and we know that trauma is often a precursor to these conditions. Not only do we need to prevent trauma, but we need to promote trauma-informed care as well. And third is rights and the importance of protecting the civil and human rights of people in recovery. Just want to end my brief remarks here to thank you all for the work that you do in terms of supporting the workforce, helping to sustain a workforce that can ultimately help all of us in our shared goal of promoting recovery, to keep our eye on the prize for all of us, to help support people to have a full, happy, and productive lives in their community. Thank you all and enjoy your day.
Thank you so much, Paolo. This is we feel very grateful that you're here with us today. And do you share the 5 amazing goals? Because those 5 goals have been representing throughout the day. We not only talk about inclusion very intentionally and outreach and a sense of belonging, we talk about a stigma. Even yesterday, when our colleagues were talking about, we were having a presentation about peer support programs that train peers that are deaf and hard of hearing, and they were discussing how much stigma there is around that. Definitely mention the social determinants of health and definitely training. This is what the TTCs are all about. So we love to learn about those 5 goals and learn about the importance of data as well. So we really appreciate and congratulations on this new office. So now, without further ado, it is my honor to introduce you to our keynote speaker, Dr. Jonathan Edwards. He's a social scientist, a public health professional, a licensed social worker, and a person in long-term recovery. He led the largest peer support workforce within New York City hospital system at the Kings County Hospital Center in Brooklyn. Jonathan's contributions to peer support include research on job satisfaction, involvement in the National Association for Peer Supporters, and developing practice guidelines that are very needed, an independent consultant. He is a certified peer specialist, a certified personal medicine coach, Dr. Deras also serves as an adjunct faculty at Columbia School of Social Work, has received several awards. He's the co-editor of numerous articles and recently published book, What It Takes, Wisdom from Peer Support Specialists and Supervisors. Jonathan received his PhD and master's degree from the social welfare from the City University of New York Graduate Center and the master's in social work from Hunter College. So Dr. Edwards, it is a privilege. Congratulations and to recent published book on Valentine's Day per se. I have not had the honor to meet you personally, but I know you are very close with our colleagues and our director and the Yale Program on Recovery and Community Health. So welcome, Dr. Edwards.
Thank you. Thank you very much, Maria, for that beautiful introduction. And good morning, everyone. I'm really excited to be here. And I like to start out by just taking a moment of silence and breathing and just letting you all know that hearing my own bio makes me wonder, who is that person? And it's because of one of the central themes of today that I'm able to be here, my own personal recovery, which is really the driving force behind my professional life, my scholarship, my interests, and my research. So I want to give greetings to each of you this morning, and I'm truly honored and humbled by the invitation to join you at New England Mental Health Technology Transfer Center 2023 Innovations Conference, which is about honoring workforce solutions to support care for communities of color. So in addition to illustrating connection between my message and the event theme, I will also share with you why the topic of peer support and recovery are so important to me. This is one of many opportunities to present some of the merits, some of the challenges, lessons learned, and so forth during more than 2 decades working in the areas of mental health, substance use treatment, and peer support. So I've been blessed to amass a wealth of experience as peer support workforce advocate, researcher, public health professional, academician, peer supporter, and a person who can be present today as a result of what many of us call the recovery journey. Throughout this talk, I will use the word recovery in 2 ways, or in at least 2 ways. And one of those is a process of change embraced by many individuals, including myself. And 2, a system transformation, particularly the exponential growth of peer support services and the increasing necessity to develop infrastructure to sustain peer support within these various systems of care. And lastly, to honor the value of experiential knowledge. Before I move into the body of my presentation, I have several disclaimers. And the first is that I will need to occasionally pause and hydrate, and I encourage you all to do the same. I will drop names because after all, I could not be on this journey without the encouragement and support of many of you who are here today. And I just saw my colleague and mentor, Dr. Sherelle Bellamy, pop up in the chat. So I can say that I'm successfully multitasking because I'm acknowledging you, Dr. Bellamy, for all the guidance that you continue to give me. And third, I have a 2-year-old male cat, and he may emerge at any time to make his presence known, but I will do my best to stay on track. And I wanted to make a slide of him. His name is Clyde, but I was afraid he would get more attention than I would. So I said, I'm not going to spend time trying to do that. But he's here on the chair beside me, and as long as I don't try to constrain him or put him in the room, I think all will be well. So at this time, I want to invite you all to join me in a moment of silence, and this is voluntary. And this is to acknowledge our fellow peers and colleagues who have moved on. I would like to especially remember my very dear friend and colleague, Celia Brown. Celia was one of the first peer specialists many of us knew, and someone who was instrumental in establishing the peer specialist civil service title in New York State. So I'm just going to take a moment of silence and just acknowledge and think about these wonderful people that we've worked with, that we've loved, that we've been inspired by. So thank you for that. So earlier we had the opportunity to hear from Paolo Del Vecchio, someone whose work and just amazing movement in SAMHSA over the years. And I just have to say, Paolo, it's wonderful to share the stage with you, even a virtual stage. We had the opportunity to hear from you representing the newly formed Office of Recovery about movement at the national level to leverage President Biden's acknowledgement of peer support in his unity agenda. And the specific excerpt that I want to quote is around President Biden's message to build a national certification program for peer specialists by convening stakeholders, launch development, and support implementation of a national certified peer specialist certification program. This program will accelerate universal adoption, recognition, and integration of the peer mental health workforce across all elements of the healthcare system. And I'm really excited about this. And I also believe in being transparent. Peer certification is a very gnarly and controversial issue, so I will not try to paint it as purely rosy, but there are some pronounced pros and some cons that I think we can certainly work through. And I did have the opportunity to work with wonderful people on the technical expert panel last week, and I really appreciate that opportunity. And I have high hopes that we're going to come up with something to really help to mobilize this effort. So my observations over the years, as well as compelling data, bring a very stark reality to light. There are commonalities across behavioral health workforce, regardless of whether one identifies as a peer or a non-peer worker. So I'm going to be talking largely about peer support today, but I do want to make this connection. It's a very important connection because one of the other things that President Biden's unity agenda sought or speaks about is the importance to promote the mental well-being of all frontline workers. Okay, not just peer support workers, not just social workers, not just licensed creative arts therapists, not just family therapists, but all of us. And this data was very, very alarming to me that 3/4 of frontline healthcare workers report burnout, while more than half say that they lack adequate supports to cope. The administration has already dedicated $103 million in American Rescue Plan funding to address burnout and strengthen resiliency among healthcare workers. The president will strengthen this commitment by signing the bipartisan Dr. Lorna Green Healthcare Provider Protection Act into law, which will invest $135 million over 3 years into training healthcare providers on suicide prevention and behavioral health, while launching an awareness campaign to address stigmatization, promote help-seeking and self-care among this workforce. And in addition, Health and Human Services will continue grant programs to support health systems and provider groups to prevent burnout, relieve workplace stressors, administer stress first aid, and increase access to high-quality mental health care for the frontline healthcare worker. Now, I know that was a very long excerpt. I read through it several times, and I think it was all important to read verbatim. This is just an amazing commitment. And I have, once again, high hopes that this will make a difference in supporting our workforce, particularly our workforce who cares for communities of color. Now, many of you are on the front lines working with individuals and families at various stages of their healing and recovery. And I know that some days it feels like pushing a boulder uphill. I know from my own experience that we do reach new vistas. We can renew our hope and we can reflect on steps taken and challenges overcome. So I also just want to take a moment to let us be affirmed by what we have accomplished as we move forward to accomplish even more. So in thinking about how I would like to talk about peer support in particular, an alliterative subtitle, Discourse, Dimension, Discovery, came to mind several weeks ago. And for me, these three foundational concepts, discourse, and that's to describe the emergence of peer support as critical connection and mutuality between individuals with similar lived experiences. 2, dimension, to illustrate the breadth, depth, and multifaceted nature of peer support from its autonomous, non-monetized, non-hierarchical origins to its subsequent attempts to successfully implement peer support in mental health, substance use, and other systems of care. And third, discovery, to explicate how peer support is burgeoning within mental health, substance use, justice, military, family, and youth sectors. The images that are being shown on this slide, and I hope the slide is up with the various pictures on it. I think it is because I'm looking at it. You know, this slide to me, I put it together last week and, you know, I just wanted to do more. I did what I could. These images represent the discourse, dimension, and discovery of peer support locally and globally. And I just want to point attention to the upper left-hand image is a late 18th century account from Jean-Baptiste Poussin and Philip Pinel, who reported unrivaled connection between former and current patients at Bicêtre Hospital in Paris. In contemporary Zimbabwe, if we go to the lower right-hand corner, we can't see the large orange structure, but Black women, and I say that emphatically because I am proud that Black women occupy orange structures known as friendship benches, where anyone seeking support knows where to find it. Peer support also exists among soldiers impacted by trauma incurred through military combat. And there's some great research through the military defense centers of excellence. Students in the educational system utilize peer support, and we could see our wonderful students here, and thank you for putting the cursor over that picture. And then promotoras, and I learned about promotoras in doing my dissertation research. They are lay Hispanic Latino community members who receive specialized training to provide basic health education in the community without being a professional healthcare worker. There are also people who are dealing with mental health and substance use issues, HIV, and cancer care. We support one another under various titles such as sponsor, coach, and bridger. Fire starters use Native-focused peer recovery programs based on the traditional knowledge of tribal elders. For example, following the elders' 4 laws of change, White Bison particularly has demonstrated the program capacity to build indigenous support communities of well-briety, which are facilitated by these healthy and sober spiritual leaders. In other words, peer support, although a unique approach, is not uncommon, just not as widely known or understood for its potential value add to multiple systems of care. So if I may wax poetic for a moment, peer support is neither uniform nor static. Rather, I say that peer support is a fluid practice that involves bending with the wind and blooming in the sun. I once heard someone describe peer support as, quote, the willingness to remove one's own scab to help heal another person's wound. And I wish I could take credit for that, but I heard it and I'm quoting it. Several definitions that continue to resonate for me around peer support. The first one is from my mentor, Phyllis Solomon, another mentor, and she defines peer support as, quote, social emotional support, frequently coupled with instrumental support that is mutually offered or provided by persons having a mental health condition to others sharing a similar mental health condition to bring about a desired social or personal change. Sherry Mead, who many of us know, who developed intentional peer support, defines peer support as a system of giving and receiving help founded on key principles of respect, shared responsibility, and mutual agreement of what is helpful. Peer support is not based on psychiatric models, Mead contends, or diagnostic criteria. It's about understanding another's situation empathically through the shared experience of emotional and psychological pain. And someone whose work I've admired for many years, Dr. Larry Davidson, wrote that peer support is based on the belief that people who have faced, endured, and overcome adversity can offer useful support, encouragement, hope, and perhaps mentorship to others facing similar situations. I want to pause and invite each of you to type into the chat 1 to 2 words that come to mind when you think of peer support. And I'm asking you to do this because I don't have the pleasure of being in the same room with you physically, seeing your faces and interacting with you. So one of the things I like to do in a virtual space is to try to invite some interaction. So I'm seeing two-way from Sarah Johnson, parent to parent. Yes, it's important that we talk about parent-peer support. Let me see, bridges, understanding. This is great. Strength-based resiliency, individual people who share, connection and respect. Keep them coming. Okay. Well, it looks like we got quite a few. Authenticity, yes. Working side by side. Normalcy. Thank you for that. Usually we're being called abnormal, so I really like that. Normalcy. Vulnerability. Building each other up. And up is all caps. Connection and camaraderie. And I'm sorry I'm not calling your names, recognizing you individually, but these are coming really quickly. Stories, finding the wisdom in experience. Connection. So thank you for these, and I just want to acknowledge the ones that will continue to come that we will certainly refer back to later. So some of you may wonder why I invited you to partake in this activity. In my attempts to create some interaction, I want to also draw upon your wisdom in laying the groundwork to, one, talk about peer support as value-add, recovery-informed engagement that is available to any person seeking it, whether in treatment or not. And two, to synthesize a few significant points before closing shortly. So there are three reasons why I want to propose peer support as a workforce solution, okay? And I'm not quoting hardline research. I've taken some information from various sources, but I'm certainly prepared to back it up with research if that's what you want. So I tried very hard not to make this a research presentation, so I will begin by saying that peer support, as we all know, is a rapidly growing workforce. Peer support as an evidence-based practice improves outcomes and quality of life and also reduces hospitalizations and cost of services for individuals accessing those services. I replaced consumer with people who access services. Through its focus on empowerment, mutuality, and the whole person, that holistic perspective, it has the power to fundamentally change how we approach and engage people around their mental health and well-being. Next, peer support fits naturally into the current trends of healthcare. With a focus on the entire person and empowering individuals to take ownership of their own well-being, peers help those they support to stay engaged in monitoring and improving their overall health. One model that really resonates with me is Dr. Pat Deegan's personal medicine. As you heard in my credentials, I was able to take the certified personal medicine coach course, and I think it's just a wonderful way of helping a person to contextualize medication as one of the supports to their recovery, as opposed to treatment compliance as a goal, which is often the message that we get from providers. And because peers improve quality of life and outcomes and reduce the use of the most restrictive levels of care, peers also offer a strong return on investment by using resources to prevent and reduce hospitalization and other high-cost services. Also, peer support transforms systems and services, but leadership must prepare their organization for this culture change in order to ensure large, sustainable impact. The presence of individuals using their lived experience of being in treatment for mental health and substance use issues has the power to dismantle the stigma of having a psychiatric diagnosis. In other words, not only can we go back to work, but we can also make a significant contribution without being a junior clinician or someone who's been co-opted or someone who's being exploited to do duties that are outside the scope of what a peer support worker does. That's another keynote. So for me, honoring something ideally means to understand and to value it. Apropos of the event theme, honoring workforce solutions to support care in communities of color, I want to draw from implications of my own research on peer support worker job satisfaction to illustrate several points. And I was fortunate enough, and I want to also stop and acknowledge anyone who participated in my research study about 4 years ago, looking at job satisfaction among mental health peer support workers in recovery-oriented settings and in mental health treatment settings. And so one of the findings among a sample of 609 peer support staff working in different practice settings, what we found is that coworker support, perceived organizational support, supervisor support, and job empowerment explain 71% of the variance in overall job satisfaction, with age and status as a certified peer specialist as significant contributors to that variance. Organizational support and job empowerment factors explained most of the variance in overall job satisfaction. And the implication there is that as the peer support workforce continues to burgeon, it is crucial to promote peer support values, role clarity, certification, diversity, and optimal organizational and empowerment resources to sustain a satisfied and effective peer support workforce. Another finding is that more than 70% identify their race as white, and slightly more than 68% reported female as their gender identity. And the implication there is that honoring workforce solutions to support care for communities of color necessitates deep commitment and intentional sourcing and recruitment, training, and professional development to prepare more peer support workers of color. We will need to continue thinking about inequities in access to technology and information streams, for example, surveys, to which disparities in this study participation are likely attributable. And the last finding, and there were many findings, but I wanted to pull out 3 that I thought would be relevant to today's topic. The mean age of participants was 49 years. And we've already stated that age was a significant contributor in explaining job satisfaction. The average annualized full-time salary was $32,286. This is consistent with participants scoring lowest on satisfaction with pay in comparison to the other 5 subscales that measured multidimensional aspects of job satisfaction. Those are general satisfaction, advancement and security, coworker support, supervisor support, and feelings on the job. So in essence, of 6 multidimensional aspects of job satisfaction, the one that participants scored the lowest on or reported lowest satisfaction was pay. Not surprising, but once again, the data are stark. I don't know that that's a living wage. I live in New York City. I know that double or triple that it's challenging to live here. And then when we think about the mean age of 49, I move into the implication that older people who are doing peer support work naturally tend to have more life experience and also see the dignity and the value in what they do to support others. Peer support is not about cheap labor, no matter what we call it. I was reluctant to even, talk about how it helps the bottom line, because that certainly can send, messages that I don't want to represent. But peer support is not cheap labor, and if one feels devalued, then they're not going to stay. And so this has implications for, retention. Can the workforce be maintained? Can it be cultivated? Can it be appreciated? And the value that peer supporters bring is unparalleled, and compensation should reflect that. And, there are many, many debates around other credentials, and I don't want to go off on a tangent with that, but education is another gnarly issue among peer support workers. For some of us, we're seen as sellouts because we sought higher education for other reasons. Other people, I know people who are far more intelligent than I am, who may have a GED. My reasons for going into education were not to be better than anyone or to try to be the poster child peer. Actually, I've never done peer support work that was compensated monetarily. All of my peer support work efforts have been voluntary, which really holds true to the sort of basic understanding and definition of peer support as non-monetized mutuality between people who are facing similar challenges. So some of the takeaways, and I have no idea how long I've been speaking. It looks like, I don't know, maybe 17 or 18 minutes, but maybe longer, and Maria hasn't given me any signals. But I do have a couple of takeaways. And, you know, although not promising any of these as panacea, I offer several takeaways to inform implementation of peer support workforce development. And the first one is to understand and practice strengths-based and trauma-informed supervision. You know, I've had the opportunity and continue to have the opportunity to do a lot of work in supervision, working with supervisors, both who identify as peers and those who do not. As it says in my bio, and I proudly boast this because I moved over from a cushy job in Central Office of Behavioral Health at Health and Hospitals Corporation to work in a facility because there was the opportunity to join and lead the largest peer support program in New York City at that time. At one point, I was providing supervision, mentoring, coaching, and support to almost 30 peer specialists, working across 5 different service settings, including the psychiatric emergency department, the inpatient units, and I would always emphasize they're not called wards, they're called inpatient units, outpatient programs. We had a program to provide support to individuals who were impacted by the earthquake in Haiti because our hospital was housed in the midst of a large Caribbean American community, and many people had relatives who were impacted directly and indirectly, and then also the partial hospitalization program. So I know how peer support services could work and operate and make a difference to people in various service settings. Supervision, therefore, it's very, very important to be strengths-based. And I would contend that this is not only for peer support specialists, but to any person working in the human services and any person receiving supervision, that there's always something that someone's doing that could be built upon. And that's pretty much like a recovery value that we use when we engage people who are seeking support, is that there are always strengths to speak to. And it's also a tenet of psychiatric rehabilitation. To elevate and promote peer support with clarity and curiosity. So as with anything else, you know, I may know a little bit about something and I can use that little bit of subject matter expertise to talk about it and to promote it, but I also have to be curious. I have to maintain the asking stance and to make sure that I'm asking more questions than answering questions. Because oftentimes when we don't know what we're talking about, and I'm really speaking of myself, what we're doing is we're perpetuating a lot of bad information, and that can lead to very, very bad situations for people in the workplace and outside of the workplace. And third, to be intentional about training and hiring more peers of color. I don't exactly have the answer for how we do that, but I know that access is probably an issue. Training, making training available, meeting people where they are, being culturally sensitive, helping people to understand the innate values that they have, and helping others in their own community. Understand credentialing, certification, and advanced education, as we call it. As I said earlier, certification is a gnarly issue. I think there are more benefits than not. And I think it's important for employers to understand what certification means. It's not licensure, but it states that a person has met minimum requirements to work in that field. And I think it also helps one to feel empowered with a sense of achievement and to understand the basic tenets, tasks, and values and principles of the work that they're doing. And always seek out resources. There's always more resources. I know we're all on information overload, but it's very, very important to always seek information. Information is always updating, and so forth. So to understand peer support again, I just want to loop around and speak to another definition by William White, and he states that peer support is the process of giving and receiving non-clinical assistance to achieve long-term recovery from severe psychiatric, traumatic, or substance use challenges. This support is provided by peer supporters, people who have lived experience and who have been trained to assist others in initiating and maintaining long-term recovery and enhancing the quality of life for individuals and their families. Peer support services are inherently designed, developed, delivered, evaluated, and supervised by peers in long-term recovery. And that's another very contentious issue, is who should be supervising peer support workers. And that's a whole other discussion. So in closing, I just want to say that I hope that I conveyed some of the reasons why peer support models should be included in healthcare delivery, and how significant the role is for maintaining one's own garden while assisting others in tilling their own soil. I contend that concerted efforts to outreach in communities of color for individuals who may have a desire to become a peer support worker could be a fruitful step. As I near the close of this segment on our virtual stage this morning, I want to invite you to take part in a wonderful exercise called Chatterfall. I learned about Chatterfall from another colleague, Dr. Jessica Wolf. And in this final invitation, what I'd like to do is to ask everyone using the chat feature, if you could type the following, but please do not hit return until you are signaled. Okay, so I'm going to ask you to type in a few words or a brief sentence that describes how you think peer support could benefit individuals in your program or your community. And if you could just write them in, and I'm going to wait about 10 seconds, Maria, if I have 10 seconds left, then I'm going to ask everyone to do something at the same time. So how are we doing? I don't see any faces, so I can't tell if people are giving me thumbs up, but they're writing things.
So Dr. Edwards, you are doing amazing in time. So actually, we are gonna have time for questions. I'm gonna put you on the screen now. You can do your exercise, and then by a show of hands, you can ask your questions in a moment. Okay, so perfect
now I can really interact. That's great.
Yes,
Okay.
I know. So you still have 15 minutes, so we're doing amazing. Thank you so much.
Okay, great.
Go ahead.
Wonderful. Okay, so let me see. All right. So if you're typing in, don't hit return yet. And if you've hit return, please type it again, because there's a purpose for this exercise. I want to see if it works. It's worked a couple of times. So I'm going to give another 10 seconds, since we have time, to type in a few words or a brief sentence that describes how you think peer support could benefit individuals in your program or community. And please don't hit return. Okay, so I'm going to count to 3. And at the count of 3, I want everyone to hit return. So 1, 2,
and
3. Yeah, here we go. Yep, Chatterfall. That's what this is called. And so everything went really quickly. So I'm going to go back a little bit and just read some of these. This is not a pre and post test, but let me see. So, wow. Okay, we got a lot. Hope I can save the chat here, use them in my next presentation. So Stephanie says, it already does so much exchange of life-saving information and leveraging of local resources. Sherelle, who's Sherelle? Sherelle says, affirming our humanity, that's why we need each other, that we need each other. Thank you, Sherelle. So glad you're here. And let me see, I don't want to mispronounce anyone's name, so the person's last name is Hernandez. I'm not going to botch your first name. Enabling self-determination and voice. Okay, Rita. Peer support can help us scale up a much needed response for mitigating isolation, depression, and anxiety. Adele says peer support offers folks confidence and comfortability with asking for help. Yeah. Tamika, I hope I said that correctly. Helping first-generation students understand how to navigate and adjust to college and new career paths. Oh, you couldn't be any more right. I'm working on a paper with colleagues providing academic mentoring and peer support for doctoral students of color, because just getting through a doctoral program as a Black gay male, you know, who's older, I feel much greater achievement over that than having passed all those classes and successfully defended a dissertation. Just the emotional labor of getting through a program and seeing others who are privileged and you're not. And that alone, paired with imposter syndrome, could really bring anyone down. So I'm so glad to see that we're speaking about peer support in the education system. And I'm also grateful that today I can say these things not through the voice of a victim, but as someone who just feels adequate to state how things were and to be a part, hopefully, of solutions. Increase everyone's capacity to humanize the people they interact with. And that was from Nicole. Taylor, encouraging and empowering one another. Maggie, peer support could help transform and provide liberation for my community. Sherelle, affirming our humanity, that we need each other. Thanks, Sherelle, again. And Paul says, supporting identification with another, each other. Eddie says, they will heal and grow and people. Okay. Lisa says, continue to hold hope while people can't see it for themselves. Yes, holding hope. Continue to hold hope, giving people someone to talk with who gets it and provide a sense of hope for the future. Strengthen the effectiveness and responsiveness to all the people who could benefit from support. And that's from Sarah. I'm going to read a couple more. Lisa says hope and local supports. Dr. Kwame says peer support has been extremely helpful in my work with individuals living with psychosis, particularly early psychosis. Okay, and then I see something that says back to the idea of normalizing. And then Stephanie says snaps. So somebody got some snaps. Thank you for doing Chatterfall. You know, to me, it's sort of like it's like a waterfall of thoughts and feelings and sentiments, and it was really fun to do that. It's also great not to do those polls, because then I would have put extra work on Maria and her group, you know, to be working polls. So I wanted to keep this as low maintenance and high yield as possible, because this is all about us. You know, I had the privilege of being on the virtual stage today, but we're all in this together. As corny as that might sound, you know, we're all co-creating solutions. We're all in the same field. And I think there's some way that we're all connected. So thank you for sharing your thoughts. And what I'm going to do now is to open up to any questions. If you could also write your questions so that if I'm not able to answer it, I can circle back with an answer in a reasonable amount of time. As they say, the check will be in the mail. So thank you, and I'm looking forward to your questions.
So please raise your hand if you have questions. I think we will save the chat as well. Absolutely, the floor is open.
So I'm able to see, okay, so let me see. Any studies of research, okay, let me read this one. So Eddie, any studies of research around workplace peer support? So Eddie, I'm going to ask if you would unmute and just, you know, give me more information about that. Any studies or research around workplace peer support? You mean peer support in the workplace?
Yes.
You know, that's a really good
very
question.
much.
Yeah, that's a great question, because we're always talking about researching peer support, its effectiveness, what people know about it, its theoretical base, randomized control trials, but how it would operate, I guess, among employees within a workspace. There probably are studies. I don't know of any offhand.
Okay.
I would say that the closest that, and this is not a study, but the closest that I came to operation and any operationalizing anything like that was supervising 18 peer specialists across 6 inpatient psychiatric units and trying to implement a group supervision model, and then sort of seeding it, but then stepping back from it and you know, I don't want to say empowering, because I always believe you don't empower other people, we empower ourselves. People could support us in empowering ourselves, but I stepped away from the group, I provided some time for them, but then I encouraged them to be on their own so that they were able to not only exchange workplace solutions and different ways and approaches to support others, but also to have their own rap session without their supervisor being present. As I said, it's not a study, but it was one of the ways that I could legitimately embed peer support into a traditional system without having to oversee it, and to sort of foster a sense of autonomy that people would have, so that they can experience that peer-to-peer support without feeling like, yeah, well, this guy's a peer and he's understanding, but he's also our supervisor. We're not going to be able to say what we really want to say, even if it's about him. So I think that would be really interesting to study how peer support works among workers within a practice setting.
Yes. Because we hear about it on a warm line, we hear it about, hotlines or at the hospitals and many other things, but not in the workplace generally.
And with about the hotline, can you give us an example, what you did here?
In Maine, we had a peer center and we answered calls on a warm line of other peers looking for resources, hope, connection, just maybe some time to share a conversation.
Yeah, I certainly know about warm lines, and those are really important. And one also can keep their anonymity and also get the support. So I think that that's a good
Exactly.
That's a good way. Well, thank you for the work that you do. And what do if I might ask, are you a peer support worker or in another title or both, several titles?
I am currently disabled and was a peer support worker on the warm line and at a peer center for 2 years.
Well, one of the things that I was able to share is that, I've never actually been paid as a peer support worker. And it feels a little bit privileged and lofty, but I'm glad that I can do something that I love without, the monetary gain. And at the same time, I want to acknowledge how important it is, and it is burgeoning in our workforce, and I believe in it. And I guess I'm saying all that to say that no matter where we are or what our current abilities might be, is that we're always able to help someone else. And I think, that's why one day I decided that I was able to get out of bed. That's just my story, is that I didn't have to feel great or be great to help somebody else. And that's just my story. It's not lecturing. I just wanted to share that as a reflection to what I got from what you said. So thank you.
Thank you so much for sharing.
Okay. All right. So let me see. Do I think that a national or state certification would improve pay for peers or create more barriers instead? What a great question. Right off the top of my head, I would say the former, that I think that it could potentially lead to improved pay in peers, because I think it would band more peer specialists together. I think it would make it a more visible, I don't want to say standardized, but a more visible entity. I mean, right now, there are 47 states that have a vehicle to bill Medicaid for peer support services, or there are 47 states that have a peer support certification. I might be a little bit off. I tend to think that it could have more positive impact than not. I can't think offhand of any barriers, except so different states have different requirements for testing. And I know, SAMHSA just did a wonderful sponsored a wonderful report that was done by the Peer Recovery Center of Excellence. And we got the data last week at the technical expert panel. And I think there were a handful of states that have a fee associated with one becoming certified. And sometimes fees can be a barrier to people. I talked earlier about access and inequity. And, unfortunately, a certification could, in fact, pose a barrier to, say, more people of color or people in rural areas. And so there is that inherent possibility that it limits access to people being able to test and to achieve that credential. I would say, therefore, that both exist, that it could have some positive effects, and it can also have some fallout or become a barrier for others, depending geographically and also based on other demographic factors.
Right. Thank you so much. This is all the time we have for questions. I think Paolo Del Vecchio and Dr. Edwards have made an amazing, I am totally inspired by the conversation we're having this morning. One thing that I just want to wrap up, as you well did, talk about the intentionality of workforce development. And I think this is something that this group working together has actually been doing for the last 4 days. So I now going to invite you to an amazing wellness break so we can practice what we're discussing here in the last 4 days. Led by Sarah Johnson. She is the coordinator in Maine, so she's going to share. So I invite you to mindfully invite the 2 presenters this morning to stay and welcome back to the panel at 12:10. We're going to be hearing now practical solutions to address all these issues that have been discussed throughout the 4 days. So without any further ado, I think you can go ahead, Sarah. I know you're going to share your own screen.
Thank you, I am. I just want to share before I begin to share some poetry with folks this morning, that if you need to stretch or grab a drink of water, please feel free to do that while I read. And I'd like for folks to think as I go through these pieces of poetry about some themes that we've been sharing over the course of the last 4 days that I think these poems also will share, including being present, the duality and the changing of your inner experience, generational changes, self-love and self-care. I sought to share these poems with you all because I feel like they go with those themes that we've shared. And I also just want to quickly put in the chat some language that is in a few of the poems that may be disturbing to folks. And I just want to put that on the table before I begin to read. So I put those in the chat and now I'll share. I've been my curious daughter, exploring and testing, messing up, being bold and carving my own path with some permission and some forgiveness. I've been my loving mother, giving her space and boundaries, not always sure what she'll do, amazed by her, angry with her. I've been caretaker and I've been loved. I've given myself space to be both. Some people will look at you with love because of you. And some people will look at you with love because of what you reflect about themselves. And it can take your whole life to figure out the difference. And it can take your whole life to figure out if you mind the difference. I have no spare parts. I have everything I need and not a bit more. I don't yet know how to use all the parts of me, and I don't know where to look for some parts yet. But nothing is extra, and everything is or will be necessary. I am not wasteful. I need every part of me. If you thought it'd be a waste to look down, you'd be missing the lizards. You'd miss the 4-leaf clovers and the ants carrying off their meal. You'd miss the caterpillars, the sidewalk cracks that look like a state. If you never look down, you'd never see the paths your feet find and the earth you're connected to. And if you sometimes look down just for a minute, you might realize the little things in the world can be so beautiful. Lately, I've been reaching in. When I feel I need something, I reach out. I get things done through people, fully embracing our shared need for community. But lately, when I feel a personal desperation, I've been reaching into me. I already know that a brisk walk will clear my head. I already know how I like my coffee and when a sip will fill my soul. I already know what whispery songs I need my heartbeat to fall in alignment with. I already know which rooms in my house flood with sunlight just the way I need. I already know what soft t-shirt I like hanging off my shoulders. It's uncomfortable to sit with myself, but I can fix me. We give our children, make sure you clean the lint trap when you do your laundry, baby, or you'll start a fire. We give them vegetables on rocket ships so the fantasy outweighs the flavor. We give them a blue shirt or a red shirt for school today, sweetie. We give them, it's so sunny and warm, go play outside for a little while. But what would we keep from giving them if we knew we had a choice? What wouldn't we give them if we knew we were giving it at all? What misperceptions, what bias, what pain, what anger, what self-doubt, what confusion, what weight, what mania, what coping, what hidden things? What would we have kept from handing over to them if we had the chance to see we were handing it over? Wrapped in a bow or slid across the kitchen table silently around the elephants in the room. What things would we have killed within us before they had the chance to slither through time any further? Your gene pool finally acidic enough with you to kill all the germs. What pitchforks we could put down. Clean it all out, baby, so your torch doesn't start a fire. I think about the word dismantle, to take apart piece by piece. And sometimes I think people get overwhelmed that there is so much to do, and there certainly is. And sometimes I get overwhelmed. But the ask of us isn't to destroy or demolish or obliterate or annihilate, though those things might be nice. The ask is for us to dismantle, to each take up a hammer and start pulling nails. Take your load to the dump, or place it by the curb, or burn it, or find a better use for it. And that's manageable.
Mhm.
Our strength is in proportion to our dangers. So when we've been heroes, when we've scaled our mountains, slayed our monsters and beasts, won our fights, and come home, battle-scarred, ears still ringing, we collapse into the safety we barely recognize anymore, and we feel weak. Without an other to battle, it feels we've no fight left at all. And reflecting back on our war stories, what armor we wore, what we had to be to make it back to this very place, we see our now selves through our then eyes. Weakness that would have gotten us killed.
Mm.
The harder battle then begins to not start a war at home, to leave our warrior where they were needed, when they were needed, when they aren't needed anymore. Saying goodbye to her is harder than forging her from steel. It felt brave then. It felt necessary. Now the armor keeps the good out when there is less to be protected from. It doesn't serve as strength anymore. The strength is in the softness, though the softness often feels like the devil I do not know. Safety feels like a dirty trick that you just have to let get you until it doesn't feel like a trick anymore. I got home from a long day, and without the will to carry myself from the car to the house, I turned off the car and I sat silently in the yard. But after a minute, a groundhog waddled over and scooched under my car. A high-pitched bird took up peeping in the tree near me. The sun slipped out from behind a cloud. And I felt that while we may not always belong in the impossible web of human everythings, we often fit just fine in the gentle flow of natural nothings. That's it from me. I encourage folks, if anything today that I shared stuck out to you, please feel free to share in the chat. And if you have any piece of art or song or music or poetry or dance that you can link to, if you would be willing to share that in the chat as well, so others can access that and think about the connection that we have as whole people to the work that we do and the artists that we are. That's it from me. I'll stop sharing my screen and turn it back.
Wow, Sarah, thank you. Thank you. Amazing read. Exactly what we needed. So I hope you all recharge and welcome to our last hour, or I guess I should say 50 minutes. It is now my pleasure to introduce our colleague, Dr. Ashley Stewart, who is the Director of Health Equity at C4 Innovations. C4 Innovations is one of the partners of the New England Mental Health TTC, and she's going to be leading the panel today, as I shared before. And if you just join us, we are going to be hearing from 3 amazing organizations that are distributed around the country for different strategies around workforce development. As a reminder, each panelist going to have to stick with only 7 minutes. So I'm going to be the timekeeper and turn it over to Ashley. Welcome, everybody. And I will continue to share the slides as we have discussed. Thank you.
All right, amazing, amazing. Thank you so much for having me, and thank you for the wonderful opportunity to be here, a part of this amazing panel, and to kind of facilitate a discussion, although I know, as I am, many of you are just so excited to hear a bit about what our amazing presenters have been doing and what innovation has looked like for them as it relates to a sustainable workforce. As mentioned, my name is Dr. Ashley Stewart, and I'm the Director of Health Equity at C4 Innovations. And my work is related to innovation in the workforce, tied and connected immediately to identity-based forms of oppression and how we can reduce harm by the implementation of equity-first practices, culture change policies, procedures, all that and above. My work really centers on looking at what in partner engaging mapping, North Star guiding documents, equity-first framing, accountability and communication structures, equity-centered, trauma-informed organizational practices. And I absolutely love what I do. And so that gives me the wonderful opportunity to facilitate some conversations, some discussions with our amazing presenters. And so the slides might be in a particular order. Okay, thank you very much. And so we'll go in the order that they are here. What's going to happen is that our presenters are going to come up and they're going to take about 7 minutes or so to tell us a little bit about their organization, tell us about the work that they do, and tell us about how innovation is a critical part of their work. And so up first, we have Stephanie Campos from Proceed Inc. And Stephanie, I turn it over to you. Thank you.
Thank you, Ashley, and hello to everyone. My name is Stephanie Campos, and I'm a program manager with Proceed Inc. NASA, which stands for the National Center for Training, Support, and Technical Assistance. We are headquartered in Elizabeth, New Jersey, but the National Center does do work across all of the 50 states, Puerto Rico, and the U.S. Virgin Islands. Our department is sort of the national training branch of our nonprofit organization. We, as an organization, we are a community-based organization, community-led, minority-governed, and serving literally from leadership to our staff. We all live like 5 minutes from the organization. So we live in the community, we serve the community, we are the community. And what our workforce development programs and trainings look like is basically, in a nutshell, we use a variety of modalities, tools, and just different forms of partnership to provide the public health workforce, whether it's leadership from organizations all the way to folks that work in the departments of health, promotores, with the tools and the training that they would need in order to service their constituency better. So basically, we manage different types of health equity programs and and work that really centers the community, is centered around community and partnerships for sustainability. So, you know, one of the projects that we've been working on recently, that when I heard about this conference, and it's what you see on the screen, it's called the Poder en Salud project, really came to mind as sort of just like a highlight of one of the programs where we are aiming to work around bridging health disparities and reaching health equity. And what the Poder en Salud project focuses on is COVID-19 and the Latinx community in key states and regions where the disparities were high. And what makes this project so sort of unique is that we took a very multifaceted, culturally nuanced, multilingual, multicultural approach to helping Latinx communities respond to the pandemic at that time when it was so critical. You know, in 2020, when COVID first hit, the vaccine wasn't even out. As we know, our BIPOC communities were suffering from high case rate, high mortality rates, job losses, losses of family member, you know, and the list goes on and on. So the CDC commissioned us to, you know, sort of design some sort of project or intervention that could help respond to this need immediately. So what we did was that we essentially put together a coalition of Latinx led and serving organizations across key states, Puerto Rico and the USVI. We came together very quickly to try to identify what pockets within each one of those key states or areas were being hardest hit by COVID and how could we respond to it. So, you know, we were sort of in the position to sort of bring the leaders together, because in order to work with community, we know we can't go into the community and do the work. We have to work with the folks who are the leaders in those communities, whether it's the promotores, just lay members that the community knows as leaders, and asking them, what are the true issues? We know what we see on the data on one sense, but we know the data never tells the whole story. So really going to them to ask them, what are the needs? How can we best get this information out to the community so that they can mitigate the adverse effects of COVID and what's happening outside of COVID? And so through those conversations and partnerships that we built a strong foundation for, we were able to, you know, train over 70 promotores across these different states. We designed a COVID-focused promotores TLT training of trainers, all in Spanish. We, with the community, partnered with them to develop very culturally and linguistically and situation-specific public health messaging around COVID-19 prevention, vaccination, dispelling myths, dispelling mistrust, misinformation that was developed by community members, again, and the organizations and the groups that live there, and really just basically created a coalition where the expertise was already on the table, right? Because as we know, you know, we're not a homogenous group. So each Latinx community that we worked with had very specific issues that they were facing, whether it was, you know, so just to give an example, some groups work with farm worker, migrant workers. We had other who we call core partners, which were the lead agencies to lead the project. Some were working with just very, you know, spiritual leaders and churches. Others were working with only Latinx youth. And so whether it came to age, religious background, sexual orientation, gender identity, just basically so much intersectionality was part of the project. And even though we had a framework that we designed, and, you know, we used a collective impact model to achieve this change that we all wanted to see, it all looked very differently locally. So we put together a national response, but that was implemented and tailored in a local way. So I think that just overall, and this is just really a small example of some of the work that we do with public health workforce, and oh, I see Ashley back on. So I think that might be my time check, but I know there's going to be a time for questions and answers later. So I'm happy to talk more about it later on. If you had any questions, please jot them down. Don't forget them. And then I guess we'll open it back up later. but thank you.
Thank you so much, Stephanie. Yes, absolutely. And I know a lot of questions popped up for me and things I want to engage more with. And I'm certain that the folks who are here, the 66 of us in this room, want to know a little bit more. So we will definitely have time for that. Next up, we're going to have Dr. Luis Torres-Hostos talk to us today about the incredible work that's happening at the University of Texas, Rio Grande Valley, and clearly telling us about how to expand the behavioral workforce in addressing the crisis in social work licensing, which is a very timely topic.
Thank you so much. It's a pleasure to be here. I'm actually in Mexico City attending a conference, but when I was asked to be part of this group and I saw the theme and who my colleagues were going to be, I just couldn't say no. So I'm delighted to be here. Maria, are you advancing the slides? You can do, there you go. So I'm going to very quickly talk about licensing, and most of us know this. You know, the need for behavioral health professionals and peers continues to increase. The pandemic has really brought us into focus that mental health impacts everybody across the board. Unfortunately, we know that the availability of licensed behavioral health professionals continues to lag, and this is especially true in our Black and Brown communities. What I'll talk about is licensing disparities, which have existed for decades. I mean, they're not new, but as more data becomes available and we realize the extent of the problem, we're truly alarmed. And in social work, I'm the dean of the School of Social Work at the University of Texas, Rio Grande Valley, down on the US-Mexico border, where 94% of the population is actually Latino. And we have a shortage of licensed social workers. The release of the data by the ASWB last fall was truly alarming for most of us across the country. And if you can go to the next one, I'm going to quickly go through these, and these are available. I'm happy to share them. ASWB distributed these last fall. We've been asking for the raw data, and it said they gave us this summary. And I'm not gonna highlight all the troubling information that it's here, but I will call attention to two things. You'll see near the top the percentage of all test takers who eventually pass the test, and then below you'll see what that percentage is for various groups. And I'll focus on Hispanics and African Americans. So 81% of all test takers eventually pass. We do not know what eventually means because they did not release the raw data. So it could be twice or it could be 10 times. You know, different states have different rules about it. But if you're Hispanic or Latino, that drops to 59%. And look at the percentage of our African American brothers and sisters. My wife is actually African American and a social worker, but look at that percentage, 38%. That means there are 62% of individuals, African American brothers and sisters with a bachelor's in social work who will never be licensed, right? And of course, if you're 50 and older, it's 59%. If English is not your primary language, it's 50%. So this is troubling. Let's go to the next one. That's the LBSW. The next one is the master's exam, the LMSW, right after you come out of school or right before you graduate with your master's. Again, 86% of all eventually pass. We do not know what eventually means. But if you're Hispanic or Latino, that drops to 71%. If you're African American, it's 52%. So still hovering around that 50%, right? And if you look at our white non-Hispanic brothers and sisters, that differ from 86 to 91% is not a huge jump, right, in percentage. But the number of test takers that are actually non-Hispanic white must be much larger in all of these groups to be able to account for these stark differences in percentages. And then if you go to the next one, the clinical exam, 88%, that's the LCSW, 3 years post your MSW with supervision. And in different states, again, there's different regulations about who can provide that supervision. 88% of all test takers eventually pass, 77% if you're Hispanic or Latino, 50% if you're African American. So this is really, really troubling. So if you go to the next slide, what are we doing about this? So we are, Maria, there you go. So what are we doing? So we're doing a lot of different things. And again, it was great of ASWB to finally release this. We knew that it was bad. We just didn't know how bad it was. And so we're organizing. So there's the National Association of Social Work Deans and Directors is organized, and we have a couple of task forces that are looking at different alternatives. We've actually met, a subgroup of us has met with the ASWB and presented some suggestions to them in the spirit of collaboration. We don't want an adversarial relationship with the boards. We're on the same level. We want to increase the number of licensed social workers. And we asked them to consider that the fee cover more than one attempt. How many? It's open for discussion. We asked them that they go to a modular pass for repeats. Those of you that are social workers and licensed know that, or have taken the test, that it's modular. But if you fail just one module, you still have to take the entire test. So we're pushing for you to only have to retake the module that you pass. And above all, we're asking for them to release the raw data so that people who are experts in these things can actually slice it in all kinds of different ways and try to figure out where the problem is. But we know the problem is with the test, right? The social work is a large profession. There is great variability across the country, and the test has to better reflect that diversity. Apart from the conversation with ASWB, and we are also exploring alternatives to licensing. I want to make it very clear that very, very few people, and they are mostly alone in this, are advocating that we move away from licensing. That is going backwards. You would never ask physicians, the medical profession to not license, or the legal profession to not license. So we shouldn't ask social work to not license. So we are exploring alternatives to licensing. We're also coming together in state-by-state legislative efforts to push for change, and with some measure of success. There are a couple of states that have actually done away with the LBSW exam. So just the bachelor's from an accredited social work program gets you the license when you graduate. The same thing at the master's level with the initial license, the LMSW. And we're hoping that some of the larger states like New York and California and Texas follow suit. But in order to achieve that, we have to educate our legislators, most of which don't really understand this much. And what are we doing at our end? So we're also working at individual programs. And in our program, I am funding a pilot through my own funds to prepare students to be better prepared to take the test. So the students apply. We're providing the funding from my budget. They have content reviews, test taking and stress reduction skills, practice tests, mentoring, and conversations about licensing. And the most important thing is we're in one of the poorest areas of the country. We're giving them a 50% stipend to help with the cost just by participating. And all they have to do is take the test, the LBSW or the LMSW, and share the results with us. And we have 1 year under our belt, and the passing rates were already higher than they were in the past. So I'll stop there, and we can talk more about it in the discussion section.
Thank you so much. Thank you. All right. I don't know about you all, but I'm getting really excited for this critical conversation we're getting ready to have, because seeing how important innovation and being willing to take that next risk and do the work that needs to be done is so important. Last but certainly not least, we have Dr. Kwame Dance here, who is the founder of the Mental Health Access Program. I'll turn it over to you, Dr. Dance.
Thank you so much. As we found out when the panelists met each other a couple of weeks ago, that it was a well-selected panel, because all of our work really fits together nicely in terms of why I started this program. And then I'll tell you a little bit more about the Access Program. First, lived experience as a patient or client of mental health services, and having a very, 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 very difficult time navigating systems, even being in the field, and finding a clinician of color. It was very, very detrimental to my well-being at the time. So I wanted to address that need as a provider, having burnout, being in high demand for folks looking for clinicians of color, and that just becoming really ridiculous during the pandemic, and just leading to negative outcomes for a lot of my patients and clients, especially those who are in high need, especially those of color. And I told her in the chat, I'll give a little shout out. I developed the idea for the mental health access program because of some wonderful young people that I worked with in the city of Cambridge, where I'm from, under a participant that's in the chat, Nicole Rodriguez, who her kids wanted to talk about mental health. And this was back in 2017. They did a service project and a needs assessment and a research project. And what they found is that their generation doesn't carry the same level of stigma, at least in Massachusetts, that my generation had. So they wanted to know more and work with mental health. So the Mental Health Access Program. ACCESS stands for the Advancement of Culturally Competent Education to Stop Stigma. It's a mental health career pipeline program and mental health literacy and racial identity development program for Black teens. Starting in the city of Cambridge, it's now in a few sites, but in the city of Boston, and we're working on some partnerships in other states and cities. But what we do, it's a career exposure program. We connect young people to mentors who look like them in mental health fields that include social work, psychologists, licensed mental health counselors, mindfulness coaches, psychiatrists, psychiatric nurse practitioners, et cetera, so that they can see themselves in these roles. And they know a little bit about what it takes to get to those roles and what their outcome expectations are, how much money they'll be making, what lifestyles they can expect to garner interest in mental health professions. So on top of that, the programs run and facilitated by college age students. So the program serves 14 to 18-year-olds, and then college students have been running the program and directing the program and mentoring those young people about how to go through the college process. These are folks who are in related fields, and they are mentored by master's level and doctoral level students, and that's overseen by me. And it's just an example of the career pipeline. So they're seeing it at all levels. We've since built a partnership, one of our partnerships with Harvard School of Psychiatry and Beth Israel Medical Center, Beth Israel Deaconess Medical Center, to develop a program, essentially a version of ACCESS that's geared toward garnering interest for young people in early psychosis, working in early psychosis, because that's an underrepresented field. The young people in the program do community action projects as part of their work. So those have included grant proposals, public art displays, mindfulness exercises with young people in their community, guided conversations with their families. But they have to do this community piece, which taps into that stigma reduction component of the program. And we monitor them and follow them and mentor them through the program. So the program piloted in 2017 at the Moses Youth Center, and then ran its first cohort in 2019. It's a paid internship program. Two curricula have been developed. One is a 6-week, 120-hour curriculum, and the other is a 8-week school year curriculum, which the young people meet about 8 hours a week. And I'm working to build out a school-based class, essentially, that teaches about mental health and mental health professions. So we're in the works of that. We are looking to share our model with other agencies. Oh, and during the pandemic, when we were virtual, we also added a physical activity component to highlight the mind-body connection to our young people. And that's also been a very nice addition. Our young people are fabulous. We've served 127 to date. and in the program and service many more in terms of the people that they've been able to impact. So looking forward to speaking more about that.
Amazing. Thank you so much. Thank you. Thank you. So now if we have all of our panelists spotlighted with me, we're going to go in. I have a couple questions that just initially come to mind, but also to give folks an opportunity in the chat. If you have a question, feel welcome to put it in. I'll make notes of questions and make sure that we're able to direct them to the panel. One of the things that comes up for me as I listen to all of you speak is thinking about, the role of my work, working with partners through providing support to think about how to implement innovative practices within their organizations to address race and health equity, to think about sustainable and equitable change and moving beyond formative diversification efforts to make sustainable change. One of the things that constantly shows up as being paramount is that a lot of times organizations or in the work that we do, there's the stagnation, and the stagnation around ideological norms tends to come from what you all just talked about, not seeing and not talking about these different features of inclusion, but also innovation in our own journeys and process to get to where we are in terms of the work that we're doing. So that makes me think a little bit about what the role of equity is in innovation. So I'm wondering if you could speak to how does innovation support with equity in consideration of diverse lived and living experiences? And I'll pass it to whoever wants to go first. Go ahead, Stephanie. Yeah.
Well, I'm thinking about, so one of the ways that we sort of, work on community capacity building, as I mentioned before, we work with those community leaders, those trusted messengers. And a lot of the times they might be big organizations, small groups, individuals, and how that looks has to look different in order for it to be equitable. So even though we're trying to reach the same goal, how we are going to work, let's say, with a national organization that has a ton of resources looks very differently from a grassroots organization who's just getting started. And, so funding levels, how you fund them, regardless of how you fund them, how do you support them? Because the funding is just the first step. How do I support you in order for you to be successful? So does that mean we have to meet with you extra? We have to put in more time? And if that's what it is, then that's what it is. So I think it's just that tailoring, that customization of what do you need, having that open door policy, being able to practice flexibility as sort of a provider. So, your needs change. So that continuous communication, what's going on now? Okay, let me not assume that that's the same thing from when we talked last time. Now you tell me again. And so sort of just having that open door policy, consistent communication, that customization, that we can assume what that looks like based on even what we all know, because your experience might be different, but you tell me, and really responding to that versus just assuming this is what you need.
Oh, good.
Yeah. Dr. Dance, you want me to jump in, or you want to jump in?
Go for it.
Yeah, I love that that's the first question that you asked, Dr. Stewart, because of where I am. I'm in Texas, right? And I'm going to summarize my thinking in 2 words: political participation. All the stuff that we're doing at the grassroots level in our communities, in our institutions, in our associations, it's wonderful, but it could be done with a pen by a governor in one of our states. And here in Texas, a freshman state legislature, in the legislature is in session right now, and a freshman state legislator introduced a bill to defund diversity, equity, and inclusion initiatives from all public universities in Texas. And we're not alone. This is the new playbook of our colleagues on the very, very other end of the spectrum. And we have to remind our people who vote that when we're talking about diversity, equity, and inclusion, we're not just talking about Black and brown people. We're talking about women. We're talking about people with disabilities. We're talking about LGBTQ plus individuals, right? So, that is a formidable block if we can stop the divisions between us and all come together and participate more actively in the political process. And I know we're tired of it, and many of us are feeling disenfranchised and feeling like nothing matters. That is the worst possible place to be in right now in our heads. We got to change that thinking and say we matter, and we're going to pull each other together, and we're going to show up at the polling places, even if we have to crawl there on our knees.
Thanks. Yeah, I'll just jump in real quick because y'all are nailing it. But hopefully this responds to one of the questions in the chat also about capacity of my program. But one of the hardest parts, and we've been very, very fortunate and privileged to be in Massachusetts, where there actually are quite a few. There's some wonderful training programs for one in particular, Center for Multicultural Training in Psychology at Boston University. And some great clinicians of color is finding the mentors themselves, because we've been fortunate, but in terms of making it being able to replicate the program in other spaces, it can be a little bit more challenging to find clinicians of color because of all the barriers that have been spoken about already. The reason why it's so important that the Access Opportunity is a paid internship program is, just that we have a lot of programs, a lot of exposure experiences for young people that are sort of popping up now because of the demand from them and the stigma reduction efforts from them. But if we're not meeting folks' needs, especially young people, where we're starting the pipeline, we can't do very much. We can't do very much of anything, and that includes the policy and being able to, loan forgiveness, things of that nature. We need incentives for people who we need to be, better represented in the field. So.
This conversation also reminds me of how important history is in context, right? I think about some of the policies that we've talked about in just even the short amount of time. Like, this wasn't the first go around. This definitely wasn't Texas' first time trying to implement this type of policy. We've seen it show up in other states. And so a big part of thinking about innovation moving forward is thinking about how to engage younger folk. And so one of the questions that comes up in the chat, Nicole expresses gratitude for the efforts to develop and professionalize young folks to be leaders in behavioral health work more broadly. How can organizations be intentional about including youth development as part of their workforce pipeline?
So
go on, Stephanie, go for it.
I actually was just going to share something so one of the agencies we work closely with is the National Youth Leadership Council, and that's who they work with, is really trying to provide service learning for youth to not only introduce them to so many fields that they need to be involved in, but also to teach them advocacy. And one of the things that they say in how to sort of embed youth into our programming is literally inviting them to become decision makers. Mm-hmm. It's just as simple as that. So, and that has to be flexible on our part, because let's say we started an advisory group, a community advisory group, but this is happening at 9 a.m. Honey, youth are in school, so we have to be able to be flexible and, either change our hours or figure out what that looks like, because working with youth, it takes another beast, even specific times of the year. Are you going to hold a large event during prom season, during finals, when they're applying for college, graduating? So it's really understanding, what does their life look like? What does our life and goals look like? And how do we merge them so that we could accomplish what we need to accomplish? But really, it's just, we need to invite them to be at the table, and we have to be flexible to how do we get them there? And then doing, implementing some of the things that they say, not just talk, not just marking it down, but really seeing it through.
And and understanding the value of just increasing the workforce. Sometimes it just boils down to the bottom line, and we're all in industry. Even health industry, service industry is driven by the economy and the needs. So I worked in community mental health and still do. And, we're driven by productivity demands, all of that. So if lobbyists and advocates can, push for organizations to just understand the value of increasing the workforce with, young, energetic people and people of color, and being able to serve more and ultimately meet their financial demands, then I think that's important. So I think there needs to be a lot of advocacy from an economic level, as well as, a service learning level.
Yeah, and maybe I'll just add, those of us in academia also have a responsibility and also an easy way to address it, because we're always focusing on the pipeline, right? But we have to make sure that the messengers are the right ones. So, we have a bachelor's in social work program, and our average age of our students is 19, 20 years old. I'm knocking on 60. I don't even remember what 20 was like, right? So I can't be the one who's out there in the community trying to get these young people. I hire young faculty as part of our faculty who can better relate to those experiences and better speak that language, and get these young people fired up about getting involved in whether it's through education or through training or through peer supports, any way possible, but to get involved, to not disconnect because they're so frustrated with everything that's going on around us.
There's dedication. For real. Yeah.
It is. And, the word that I keep seeing populate in the chat is also intentionality. Like, it's a very intentional process. Speaking of which, makes me think of sustainability, right? A lot of times innovation or innovative ideas are charged with a really charismatic leader, a person who's really passionate about it. And one of the things that we want to ensure is that innovative intentional practices have a strong foundation to continue to show up. So maybe what are some challenges you've experienced, or when you think about the sustainability of innovation, how do you do that?
I think, go ahead, Kwame. I feel like I keep going for
No, I like it. Go for it again. Go ahead.
I think that, and it was mentioned before in terms of like working in silos or sometimes be separate. Sometimes, unfortunately, in multiply marginalized communities, we're all fighting for these little breadcrumbs, whether it's assets, resources, funding, and it's tough. I think that's one of the challenges, that sometimes there's little, and with little, we're expected to do a lot. And so then that breeds competition, and that continues that isolation, and then we're not talking because we're trying to aim for the same thing. And so that's a reality. That's a reality, and it's tough and it's hard, and it's easy to say, work in partnerships and you want to, but when you are in an environment or in an area where there just isn't much, and that's a bigger systemic issue, right? That's not anything us as BIPOC, CBOs or organizations are doing wrong. That's a big structural problem in inequity and equitable allocations of resources, which includes funding. I think that's a huge challenge.
Yeah. And yeah, absolutely. In order to remedy that challenge, a lot of the recent grants I've been going for have required coalitions. They haven't, that you need to make those partnerships and make them work with other organizations, or else nobody gets the funding. So I think that's been it's been a struggle at times, because missions may not completely align, and you have to navigate politics, especially past politics, if folks were in competition with one another in the past. But it forces folks to mend those relationships and find alignment in missions so that they can do the work in a more sustainable way.
Well said. I'll just shut up. I have nothing to add.
Well, listen, I got a 2-minute mark. So I have one more question, a quick one for each of you. The idea and concept of like getting folks fired up has been populating in the chat as well. And one of the things, we talk about change fatigue, but sometimes we get innovation fatigue because people are afraid of change. Folks can be fearful for a multitude of really reasonable reasons, experience some resistance to change. So what's something that keeps you going and keeps you passionate about this work? What gets you fired up?
I'm not gonna go first.
I got you.
Dr. Dance, you go.
For me, I've always just loved working with all ages really, but young people. I really enjoy mentorship. It's something I benefited from. I was very fortunate to have mentors in the field at a very young age, which is why I got into the field. And they always instilled in me the responsibility of doing the same. So that's been my driver.
Yeah. Stephanie, you want to go?
Yeah, go ahead, Lise.
Yeah, I mean, I'll say two things, right? Just surrounding myself by young people. I mean, that's why I'm in education and academia. And my own daughter, as I put in the chat, she's 18 and she's a senior. She's going to be going to college soon, and keeps me abreast of what's going on and how the world is changing, and if I want to stay a part of it and continue to be impactful and my work meaningful, I have to stay up to date. As long as it's easy to dismiss it. Oh, these young people in my day, right? So I swore I'd never be that person, and every now and then I find myself sliding into that person, and my daughter reminds me, Dad, don't be an old fart, right? In the second part is just remaining humble, remaining open-minded. I'm a scientist, I'm a researcher, and then we know that in research, everything is open to question. And I often repeat to myself that everything I believe has to be open to question as well, right? I have to maintain that humility. The more knowledge and experience I accumulate, the more I realize how little I truly know. And because it's easy to let all these titles and all this crap go to your head and think that you have the answer, that you're the only one who can do this or that or fix it, and we know what mess that gets us into, right? So, and that whole I'm the only one who can do this language. So let's stay humble, right? Let's keep learning from each other, and let's never stop learning.
Yes, I love that. I really think that for me, it's really just our recent shift and just movements around social justice. I love the increased visibility that we have around that. And while I want to criticize the internet and technology, in one sense, it does have some power to raise these things, right? To make it visible. And just the notion of we can come together more easily now. Of course, there's always going to be, some challenges, but just the fact that we can come together, there is a bigger platform, a bigger microphone that are bringing these issues to the light. And I think it's putting pressure, on some of those people in power, which is great. We need that pressure in order to see change. And if we can add coming together to that pressure, then hopefully we can see that change sooner. So that's really just what keeps me going.
Amazing. Thank you so much, Stephanie and Kwame and Luis, for being here with us today, for sharing your wisdom, your knowledge, and your innovation. We've really just enjoyed this conversation with you all. And please let folks know how they can keep in touch with you in the chat. And I'll turn it back over to you, Maria. Thank you.
Gracias. I am so inspired, and I am fired. So this is amazing. So I now, what a way to finish this amazing 4 days. I'm going to turn it over to our colleague. I think we can have one day per each of you, all of you. So this conversation is to be continued, and our TTCs will make sure that this continues to happen. So without further ado, I will introduce my colleague and friend, Dr. Janice Pandora, who is the principal investigator and co-director of the New England Mental Health TTC. Janice?
Good afternoon, everyone. It's great to be here. I'm equally inspired. I have the task of offering just a few brief closing remarks and some much needed shout outs. And I want to start first with thanking all of you for being here with us today and also just participating in our various offerings this past week. We hope you found it rejuvenating in terms of new things you maybe learned, new resources you became aware of, and perhaps most importantly, new connections that you made to help sustain you in your work moving forward. We've seen moments where folks connected not only with our talented presenters, and by the way, there are too many to name individually, but please know that you are all appreciated. But connecting not only with presenters, but also with each other, and sometimes with potential partners within the same state that you maybe had not crossed paths with before, And it's these kinds of serendipitous connections that really are among the most valuable things that come out of a gathering, like innovation. So it's been our pleasure to bring you all together. And earlier this morning, Dr. Edwards quoted Larry Davidson in talking about the value of peer support and how those who have faced, endured, and overcome adversity are in a unique position to help others on that same journey. And in many ways, that parallel process, it really struck me, and I wrote it down because I think it aligns with this year's innovations theme, where we recognize that in many ways, the workforce and the staff within it as a whole is in a state of crisis, but that crisis is especially felt among staff and individuals from communities of color. So together, all of you in the workforce have collectively faced, endured, and overcome much adversity, especially in recent years. And while we reflect on the role of inclusion and belonging and connection in promoting recovery among those that we serve, we do know that it's equally critical to reflect on the role of inclusion and belonging and connection as it relates to the wellness of those who serve them. So we have attempted to do that this week by covering a lot of territory at Innovations, hearing about the importance of promoting self-care for behavioral health providers, professional development pathways for peer workers, and mentorship for culturally diverse practitioners who are traditionally underrepresented in the workforce. So we hope that the opportunity to connect with one another has been as rejuvenating for you all as it has been for us. The same theme of connection that brings us together applies to the connections that really brought this week to fruition. This event and our work all year long is not possible without the ongoing support of SAMHSA. And you saw that support manifest again this week with the presence of SAMHSA leaders, Captain Jeffrey Cody, Taylor Brian Turner, Lar Kuan, Paolo Del Vecchio, and others. So thank you for being here. Innovations is also a hallmark offering of our regional network. So I just want to again offer a special thank you to our New England partners at the Addiction and Prevention TTCs, as well as William James College, and the entire committee who worked on pulling this program together for you, including our very own Ingrid Padgett, who worked tirelessly to help us both plan and execute this week's offerings. Being able to collectively pull it off, I think, is a reflection of how much we really value each other and the benefits of our collaborations here in the region. And I will say that I think the depth of that collaboration is a unique strength here in New England. And in part, that is a testament to the work of our Assistant Regional Administrator, Taylor Brian Turner. So if you are still with us, thank you, Taylor, for your efforts and leadership and helping to keep us all connected. So with that, I'm going to turn it back briefly to Maria Restrepo-Toro for just a closing word and some information on our evaluation. Thank you again for being here.
Thank you so much, Janice. And again, I just want to thank and all the partners and Maggie, you being essential in doing this. I also want to thank the Latino Hispanic Mental Health TTC for sponsoring Dr. Luis Torres to join us today. And I think you're going to receive all the information from the recordings, the prevention. We invite you to keep coming. And of course, more importantly, please remember, we do have our fund that requires to scan the GIPRA code. You can do it either directly on the screen by using this code here, or just complete the GIPRA. This is extremely important for all of the TTCs. This is the way we will continue to serve you. Remember, we're all here for you to support each other within this journey of workforce development. We look forward to seeing you next year. This is our second year, and this will be continued. So thank you, everybody, and have a beautiful spring day if you are in the New England area. Thank you so much. Muchas gracias. And we'll see each other soon.